This evening, the webinar Normal Pressure Hydrocephalus, What Your Doctors Are Thinking Before and After the Shunt is Placed. My name is Amanda Garzon. I'm the Director of Patient Programs here at the Hydrocephalus Association, along with another member of our Support and Education team, Jennifer Bouchard, who is our Education Manager. We are happy to bring this new Support and Education webinar to all of you tonight. This educational webinar is made possible through the generosity of our industry partners, Integra and Codman Specialty Surgical, who we thank for supporting this important program for all of you. Let me just start with some housekeeping, a disclaimer. Our speakers for this webinar this evening are in no way compensated for their participation in the webinar and do not represent Integra and Codman in any way. Also, the Hydrocephalus Association does not endorse or recommend any commercial products, processes, or services. Therefore, mention of commercial products, processes, or services during this webinar cannot be construed as an endorsement or recommendation by the association. The information presented during this webinar is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including graphic text, graphics, images, and information contained on or available through this webinar is for general information purposes only. Before we get started, we need to go over a few other housekeeping items. All participants will be muted. Only presenters will be able to speak. You may use the question and answer chat box to type your questions. Presenters may try to answer them as they go along with the presentation. However, there will be time for question and answers at the end of the presentation. When prompted, you may use the chat box to type your questions. This webinar will also be recorded. I would like to thank our speakers for taking the time to present this important webinar this evening. Our presenters for this webinar are esteemed members of the Hydrocephalus Association's Medical Advisory Board, Dr. Christopher J. Farrell and Dr. James Golomb. Dr. Golomb is an assistant clinical professor of neurology and psychiatry at NYU Langone Medical Center. He graduated from the University of Pennsylvania and attended medical school at NYU. Following internship and residency training in psychiatry and neurology, he completed a fellowship in aging and dementia at NYU with a focus on neuroimaging. He has served as neurological consultant for the Division of Geriatric Medicine and for the William and Sylvia Silberstein Institute for Aging and Dementia at NYU. His research has resulted in numerous scientific articles focusing on the study of cognitive dysfunction and gait impairment in normal and pathologic aging, as well as NPH. For nearly the past 20 years, Dr. Golomb has directed the NYU Adult Hydrocephalus Program, which aims to identify patients likely to benefit from the neurosurgical treatment of hydrocephalus and to provide treatment for other associated neurological problems resulting in dementia and gait impairment. His current research involves the development of radiologic techniques capable of distinguishing hydrocephalus from many of these other disorders. Also with us this evening is Dr. Christopher J. Farrell, who is an assistant professor of neurological surgery and a member of the Division of Neuro-Oncologic Neurosurgery and Stereotactic Radiosurgery at Thomas Jefferson University. His work is focused on the advancement of clinical outcomes for patients with hydrocephalus and central nervous system tumors, including the use of minimally invasive surgical approaches. Dr. Farrell is an active member of the Medical Advisory Board of the Hydrocephalus Association and Acoustic Neuroma Association. He is also a member of the AANS-CNS section on Tumors Executive Committee. Dr. Farrell performed his neurosurgical training at Massachusetts General Hospital and completed a fellowship in skull-based surgery at the University of Tennessee, Memphis. I'd like to thank both of you for joining us this evening. Our first presenter will be Dr. Golomb. I turn it over to you.
Okay, if you have, or at least know someone who has an MRI or a CT scan that looks something like this, you can see that there are enlarged fluid spaces or ventricles that in this case are maybe 2 or 3 times the size of what would be considered normal, and likely have some symptoms, including walking difficulty, perhaps some degree of cognitive impairment, and some bladder symptoms resulting in increased trips to the bathroom or maybe frank incontinence. And I'm going to further assume that on the basis of all of this, a diagnosis of NPH was made, and a shunt was placed. And so the question that we're going to explore for the next few minutes is what happens next. So for any medical treatment, whether it be a pill or surgery, there are always three possible outcomes. Either you get better, or you stay the same, or you get worse. Now, we'll start with the neutral outcome of no change. Now, assuming that the diagnosis of hydrocephalus was correct, and particularly if there was some temporary improvement following a spinal tap or a extended lumbar drain procedure, if people are not getting better, we begin to think first that maybe the shunt is just not working, or not working well enough, that it's not draining enough fluid. If you have a programmable shunt, the next step would be to decrease the pressure setting on the valve to try to increase the rate of CSF diversion. And I believe Dr. Farrell will be talking to you about the management of programmable shunts a little later. But if this doesn't work, the next thing we worry about is that the shunt may have completely occluded, and there are ways of testing for that. But if all of this checks out and people are still not benefiting, then we have to consider the possibility that there may be something else going on, that the diagnosis, in fact, may not be accurate. So we'll get back to the question of alternative diagnoses in a little bit. But first, let's take a look at the unhappy situation of things actually getting worse after surgery. When patients get worse within the first few days or weeks following a shunt operation, we need to consider a shunt-related complication. There are several things that can happen, and I think Dr. Farrell will be talking to you in greater depth about this, but just to introduce it, the first and most feared complication is a hemorrhagic stroke, or an intracerebral hematoma. And that can be pretty readily seen on a CAT scan here. The bleeding is visualized as these white clouds that surround the shunt catheter. That's this elongated hyperdensity. And the bleeding usually occurs because there was a nicking of blood vessels within the brain as the catheter was being passed. If this complication arises, we usually see it within the first 24 hours. There's also some blood within the ventricle here. Now, as bad as this looks, because the shunts are generally placed in the non-dominant hemisphere and a part of the brain that can withstand a fair amount of injury, patients can improve. And in fact, this patient showed a remarkable degree of improvement, such that at 6 months, he was really walking better than he was walking prior to the shunt. There's some other things that can go wrong as well. The shunt can work too well, and can result in an over-aggressive drainage of fluid, sometimes due to a siphoning effect. And this usually causes headaches and some clinical deterioration, and can be associated with imaging findings of slit ventricles or subdural hematomas or hygromas. This patient happens to have both. You can see the proximal catheter here entering the ventricle that is barely visualized because the ventricles are collapsed, and there are these fluid collections outside the surface of the brain, between the surface of the brain and the inner surface of the skull. And this is something that is corrected by changing the valve or changing the pressure setting on the valve, and sometimes neurosurgery to evacuate the collections. And third possibility is that the shunt becomes infected. Again, this is something that usually occurs within the first few weeks, first month or so after an operation, if it does happen. Whenever you place an artificial device in the body, it can be a potential source of infection. When a shunt becomes infected, it can cause a secondary infection of the brain. And it's usually pretty easy to diagnose this. Patients are pretty sick with headaches and fevers, and we can figure it out by culturing a little bit of fluid directly from the shunt that we can get with a very small needle. And again, Dr. Farrell will be going over this with you. Now, it's important to recognize that most patients do not incur these complications and do very well as anticipated after a shunt operation. And so we're smiling and the patients are smiling, and often the improvement persists and sometimes continues to persist for years and years and years. But occasionally we see that patients start to get worse, that the initial improvement begins to wane, and we have to figure out what might be going on. The first thing that we consider is that the shunt is not working. If there's a programmable shunt, we wonder whether the shunt setting may have been inadvertently reset to a high resistance level, and this can be checked out pretty easily in the office using a special instrument non-invasively. If the shunt is set correctly, we consider whether there might be an obstruction of the shunt catheter. If your shunt goes into the abdomen, if it's a ventriculoperitoneal shunt, usually an occlusion occurs because of scar tissue adhesions forming around the catheter openings in the abdomen, and this is something that's usually pretty easily fixed with minor surgical operation. Now, if we've ruled out a shunt malfunction, the next thing we consider is whether something else beyond just hydrocephalus might be going on. One of the tenets of gerontologic neurology is that for any one symptom in any one patient, there may actually be multiple disease processes that are operative. And the fancy word for this is comorbidity. One source of comorbidity in patients who have shunts is just the normal aging process itself. It's pretty evident that nobody walks as well in their 70s and 80s as they did in their 30s and 40s. And this often reflects completely non-neurologic considerations such as joint disease and muscle disease, as well as reflex changes. And we all recognize that falling is a very common occurrence in people as they get older and a source of considerable morbidity. And if you add even a small dose of a superimposed neurologic problem like hydrocephalus, it amplifies things and makes the problem much, much worse. This is to illustrate how our psychologic and physiologic priorities also change with age. And we begin to hear our bladder talking after a while. And we usually recognize that incontinence is a pretty common problem in women due to an overactive bladder, and in men due to an enlarged prostate. And again, with the superimposition of a little bit of a neurologic disease, such as hydrocephalus, that makes things worse. Now let's consider memory loss. Now, forgetfulness is a normal part of normal aging. People have problems with concentration and problems with multitasking and word-finding difficulties and visual spatial skills, executive function. When all of these things become serious and functionally limiting, it's known as dementia. Dementia becomes increasingly prevalent with age. The prevalence essentially doubles every 5 years after the age of 65. So that you can see here that by the time you're in your mid-80s, you have maybe a 15 or 20% chance of having a dementia. And if you add to this milder forms of cognitive impairment, such as the syndrome of MCI, which many of you probably know about. It's an intermediary phase between completely normal cognition and dementia. And if we consider the combination of dementia and MCI, by the time you're in your mid-80s, you have over a 30% chance of having some degree of cognitive impairment. Now, if you consider the various neurologic disorders that can result in dementia, the breakdown looks something like this. You can see that Alzheimer's disease is by far the most common explanation, followed by vascular dementia, which is dementia due to stroke, and a mixture of vascular dementia and Alzheimer's disease is pretty common, and then a whole host of other possibilities. Now, the thing to notice here is that our favorite disease, NPH, really explains only a very small fraction of the totality of dementia and later in life. Now, having NPH does not protect you from having these other conditions, so that the probability of comorbid Alzheimer's disease, if you're in your 70s and 80s and you're experiencing significant cognitive impairment, is really very, very high. Now, this is an MRI scan of a 75-year-old man that we saw in 2011. At that time, he was experiencing some mild cognitive symptoms, MCI symptoms. His gait was entirely normal, and there was no cognitive, no bladder symptoms. And over time, he began to deteriorate. He began to become increasingly confused, and his gait became increasingly impaired. And with a follow-up MRI scan just a little earlier this year, we see some changes in the structure of the brain. First, we can see that the ventricles have become a bit larger, but also this structure over here has become smaller. This is known as the hippocampus, and the hippocampus is extremely important in maintaining normal memory. And when we see this sort of thing, an atrophic hippocampus with age, we begin to consider that there is something going on beyond just hydrocephalus. Now, this is his PET scan. Now, many of you know that PET scans are used nowadays for the detection of metastatic cancer, but it's also very useful in diagnosing dementia. A PET scan, at least this type of PET scan, an FDG PET scan or a fluorodeoxyglucose PET scan, measures metabolic activity. And most of the metabolic activity in the brain occurs around the surface in the cortex of the brain and results in a high signal, this white color around the surface of the brain. And the normal pattern should be a fairly uniform appearance of this hyper intense signal around the circumference of the brain and the cortex. But in this gentleman, we can see a dropout of signal over here on the right and over here on the left in the parietal lobes, and a little bit lower down in the temporal lobes. There's quite a significant dropout of activity. It's about the level of the ears. This pattern of hypometabolism seen on a PET scan is pretty characteristic of Alzheimer's disease. Now, we know that Alzheimer's disease in and of itself can result in gait impairment and bladder symptoms, and particularly in the middle and more advanced stages. And we know from biopsy studies that over 75% of people with NPH who've undergone shunt operations have comorbid Alzheimer's disease. And so it's likely acting in concert with the hydrocephalus to make things worse. So what do we do about Alzheimer's disease? Well, as you probably know, that despite over 25 years of research, there's still no effective treatment. There are drugs that are available commercially that many of you, I'm sure, have heard of. The cholinesterase inhibitors, such as Aricept and Exelon, and Namenda, which is not this is an error here. This is not a cholinesterase inhibitor. It's an NMDA antagonist. But these drugs can work together to improve symptoms in patients with Alzheimer's disease. They don't change the course of the disease itself. They don't treat the underlying pathology. So the pathology continues to worsen, but they can have a modest impact in improving symptoms. We also stress the importance of physical activity and exercise and occupational therapy to improve patients' exposure to environmentally interesting activities and intellectually stimulating activities. And we can use some drugs sometimes to try to manage the psychiatric symptoms, psychosis or agitation and depression. Investigational drug trials are usually recommended, but for patients with NPH, particularly for patients who have shunts placed, the diagnosis tends to exclude patients from investigational drug trials. The drug companies establish the rules for these trials, and they want to exclude patients who have disease that may be confounding, and they're looking at trying to confine their studies to just pure Alzheimer's disease. So that's often not an option. Now, if we exclude Alzheimer's disease, we're left with these other conditions that can not only cause dementia, but can frequently result in gait impairment and bladder dysfunction. And when these conditions are comorbid, their impact can swamp the effect of NPH and result in accelerated disability despite a functioning shunt. So if we take a look first at vascular dementia, this is a patient who had a shunt operation several years ago. You can't quite see the shunt on this MRI scan, but you can see the valve assembly over here subcutaneously. And what you notice are these white areas outside of the ventricle in the substance of the brain. And this represents brain tissue that's not receiving enough blood because the small blood vessels, the small arterioles that penetrate deep within the brain have become narrowed and start to starve the brain of blood, causing this change within the white matter. And if these blood vessels begin to seal over and occlude completely, that causes a stroke. And we can see the strokes here in this patient. They're represented by these small dark holes, so that the brain has an appearance looking a little bit like Swiss cheese. Now, if a stroke occurs in a critical part of the brain, it results in an acute deficit, and everybody knows about it. But more often than not, these strokes begin to accrue silently over time. And eventually, when enough of them have occurred, it starts causing symptoms in a progressive way. And it can cause a clinical picture that looks almost exactly like hydrocephalus. Very, very hard to distinguish between the two. Now, there's no treatment per se for vascular dementia, and the strategy really is to try to prevent more strokes from occurring. And this entails treating the underlying risk factors, such as lowering blood pressure and maintaining normal cholesterol, and treating diabetes, and looking for narrowed carotid arteries and a regular heart rhythm like atrial fibrillation. Most patients are treated with blood thinners like aspirin and Plavix, and sometimes with anticoagulation with drugs like Coumadin or some of the newer drugs such as Eliquis, Pradaxa, and Xarelto if atrial fibrillation is suspected. Let's see if we can get to the next slide here. Oh, we've gone a little too far. well, okay, no, that's okay. So once we eliminate Alzheimer's disease as a factor, the remaining conditions that can mimic NPH include these neurodegenerative diseases. And neurodegenerative because they cause a progressive dysfunction of brain tissue and eventually loss of neurons. Parkinson's disease is pretty common. It can cause a gait impairment that looks pretty much just like NPH, and as the disease progresses, it can cause dementia in about 30% of patients. There's another condition that we recognize now called dementia with Lewy bodies. This is essentially a double whammy diagnosis because the microscopic pathology is a combination of Alzheimer's disease and Parkinson's disease, and presents with patients developing both gait impairment and cognitive impairment more or less simultaneously. And this is probably the leading alternative neurodegenerative explanation for a patient who looks just like NPH. It's recognized now as probably the second most common neurodegenerative explanation for dementia after Alzheimer's disease. And then there are these other more esoteric diagnoses that go by the names of progressive supranuclear palsy. Where's our arrow? And multiple system atrophy and corticobasal degeneration. And there are some others that are even more esoteric. Differentiating between all of these possibilities usually can't be made very effectively clinically because there's a lot of overlap. But nowadays we have access to an interesting tool that allows us to screen for these conditions as a group. It's called
Dr.
Okay.
You're on.
So I don't know how much people have lost here. If you'd like me to back up a little bit. But we were talking about the DAT scan, which is a way of trying to detect the presence of a neurodegenerative Parkinsonian syndrome. And the DAT scan measures something called the dopamine transporter that's depleted in virtually all of the neurodegenerative Parkinsonian syndromes, but is normal in people who have NPH. It's normal in vascular dementia as well. The normal DAT scan shows this increased uptake within the deep part of the brain known as the basal ganglia. It has a kind of a comma-like appearance to it. And an abnormal DAT scan shows presence of activity here in the anterior part of the brain, but absence of activity, absence of that comma configuration within this part of the basal ganglia known as the putamen. So when we see a scan that looks like this, we're pretty sure that there is something else going on that's contributing and maybe even the most salient explanation for a patient's symptoms. So what do we do if we think that there is comorbid neurodegenerative disease? Well, there are not too many options, but the first thing we try to do is to treat with levodopa or Sinemet. Now, many of you probably know that Sinemet is a very old drug that is extremely effective in treating Parkinson's disease, but has only a modest benefit in treating some of these other conditions, such as dementia with Lewy bodies and these more esoteric diagnoses. So if we treat with Sinemet and people get a lot better, then we're pretty sure that there is Parkinson's disease that's comorbid. The other options are really physical therapy, trying to make sure that patients don't become deconditioned and lose muscle tone and muscle strength. So we emphasize frequent walks during the day, occupational therapy. We can manage some of the psychiatric symptoms that are fairly common with these diseases, such as hallucinations, delusions, and agitation. Sometimes depression. We can do this pharmacologically. And of course, there are investigational drug trials, but like Alzheimer's disease, patients with hydrocephalus unfortunately tend to be excluded from these. Okay. So, so the moral here is that most patients who've been carefully selected for shunt surgery do very, very well, and sometimes do very, very well for many, many years. Prominent setbacks that occur within the first month or so of surgery are usually due to surgically remediable complications. When the benefit of the initial benefit of surgery begins to wane over time, we need to consider a shunt-related shunt malfunction, or the impact of progressive comorbid neurologic disease that can in time swamp the effective NPH. And alternatively, it may be just the normal aging of the brain combined with some degree of permanent brain injury from the presence of long-standing hydrocephalus can result in deterioration. So I think I've talked over my limit here, and I want to make sure that we get Dr. Farrell time to chime in. So I'm going to shut up for now and hand it back over to you guys.
Thank you so much, Dr. Golomb. At this point, since we are a little tight on time, though it was a wonderful presentation, so I'd like to ask Dr. Farrell now to step up. And we're excited to hear your presentation on the surgical treatment of NPH.
Thank you very much. Thank you very much, and Jen, it's a pleasure speaking here at this webinar, and thanks to the Hydrocephalus Association. And I think the goal of this webinar, as we talked about it, was wanted to give patients some insight, a glimpse into what the doctors were thinking along the longitudinal course of NPH diagnosis and treatment. So a little of this may be redundant with what Dr. Golomb spoke about, but I'm going to focus more on what, as a surgeon, what I'm thinking along that course. So usually basically, by the time somebody gets to my office as a surgeon, we suspect that they may have normal pressure hydrocephalus. The reason we may suspect it is that we have this constellation of findings. So clinically, the patient may have symptoms of gait dysfunction, which is really the thing that I'm really looking for. It's very rare to have NPH without at least some gait dysfunction. But then they may also have some of the dementia or incontinence or a multitude of other symptoms. They've also had a scan that shows that the ventricles in the brain are larger than they normally are. And we've gone on a diagnostic evaluation to see if any of the other more common things that can cause walking problems, memory problems, or incontinence are the primary drivers of these symptoms rather than it. So once we think that somebody has NPH, we need to figure out how to treat them. And when we look here at this side view of the brain, what we see is that we've got the hemispheres of the brain here, and they're wrapped around the center of the brain, which is what are called the ventricles. And this is where cerebrospinal fluid, CSF, gets made. And it gets produced in the center of the brain from what's called choroid plexus, red things. And it circulates through the ventricles and then around the brain and around the spinal cord and gets reabsorbed through what are called arachnoid granulations into the venous system and drains away. At any one time, you've got about 2/3 of a cup, or about 150 milliliters of cerebrospinal fluid in your whole system. And you're constantly producing that fluid, again, through the choroid plexus. This is what it looks like if you take a scope and you look into those fluids. You see, these are the ventricle lining. This is the choroid plexus that's making the cerebrospinal fluid. And over the course of the day, you make about 20 fluid ounces of this CSF. So you're constantly replenishing that CSF, and it's understandable why when you have a lumbar puncture and you get better with NPH, why quickly the symptoms recover, because you're continuously making this fluid. So the pathophysiology, the root cause of NPH, is not always just an accumulation of CSF. It's not an overproduction or an underabsorption. It's more complex than that. But basically, our treatment is to decrease the amount of cerebrospinal fluid. So it really comes down to plumbing. So in general, when we talk about treating this, we've got to find some way to send this cerebrospinal fluid somewhere else that it can be reabsorbed. And we can either access the cerebrospinal fluid in the brain, in the ventricles, or we can access it lower in the lumbar space where the CSF is draining down. And then we're going to send it somewhere else, out of the brain. The most common place that we send that fluid is into what's called the peritoneal cavity, or the abdominal cavity, because this is a large space that can handle lots of fluid and reabsorb that increased fluid. But there are a number of other places that we can send it. We can send it to the lung, we could send it to the heart, we could send it to the kidney. Anywhere where fluid exists and reabsorption occurs, we can send that. So this is the standard components of a ventriculoperitoneal shunt, which is by far the most common procedure that we perform for NPH, which consists of a tube going into the ventricles of the brain, running down under the skin to the peritoneal cavity. And this is what that system looks like outside the body. You have this catheter that would go into the brain. It's connected to a valve that regulates how much fluid is actually drained. And then a longer catheter that runs under the skin down to wherever we're sending it, either the abdominal cavity, the lung, or the heart. And the tip of this catheter looks like this. It's basically just a soft silicone tube, and it has a bunch of little holes in it that lets the CSF enter the tube and run down the whole system. So there are basically a couple of different types of valves that we use. And they're usually broken down in the categories of either what are called fixed pressure valves or flow regulated valves. There are a bunch of different companies that make valves. They each have a bunch of different permutations of these valves. On the market right now, there's about 200 different valves that your surgeon can choose to implant. In the past, most people were using the fixed pressure valves, but over the years, almost all neurosurgeons that treat a lot of NPH have moved to what are called programmable pressure valves. You can adjust this valve using a magnet to drain more or less CSF. And that's really increased the safety of these procedures. So, shunt surgery is a neurosurgical procedure. The Hydrocephalus Association estimates there are about 40,000 hydrocephalus operations performed per year. Every single neurosurgeon in the United States is trained to place a shunt. Doesn't mean we're all good at doing it or managing them afterwards, but it's one of the more routine operations that we do as a neurosurgeon. But as this cartoon says, it's only routine if you're used to someone slicing you open with sharp instruments. So we really need to think very carefully before we go and put somebody through a surgical procedure. So typically what happens is if we're placing a ventriculoperitoneal shunt, we're going to make a small incision on the scalp. We're going to expose the skull. We're going to make, using a drill, we're going to make a small hole in the skull. Typically that size of that hole, maximum size, would be about a penny. More commonly, we're using a much smaller opening. And then we're going to pass that tube through the skull, through the brain, and into those cerebrospinal fluid. The reason that this is a safe procedure is that we've used very fixed landmarks. We know that there are certain parts of the brain that can tolerate a catheter, a small catheter going through them, and patients will do absolutely fine. Even if we get complications like some bleeding, usually do absolutely fine. So as long as we can avoid a major complication, we expect the patient to do very well. Typically, the shunts are either placed over the frontal lobe, and we usually do the right frontal because it's a little bit safer than the left frontal, or the parietal area. Again, pick another safe part of the brain to reverse on our way to there. So most of the time, after we get the catheter into the brain, we're going to run it under the skin and enter the peritoneal cavity. So to get to there, to access that area, we make a small incision on the abdominal skin. The next layer you get to are these muscle layers, the six-pack, the rectus abdominis. We basically spread those fibers through a couple small layers we can get into that peritoneal cavity with the catheter, and then that fluid. So relatively straightforward operation, tends to take in an hour or two to get everything in. After this is done, what this sort of cartoon shows is that there are plenty of people just walking around with shunts that we wouldn't even know it, because everything is under the skin. Here's the catheter going to the brain underneath the skin, covered with the clothes, the hair. You don't really see these things. Look externally at them. So typically what would happen would be a patient would come into the hospital. Typically what would happen would be the patient would come into the hospital. They would have a scan that looked like this, showing the large ventricles. We would make the little opening in the skull, and we would place the catheter into the center of those fluid stains. This is what's called a coronal study, which looks back through the eyes. This is an axial, which is cross sections working from low to high. This is a shunt that's in good position. It's sitting right in the center of that fluid. Afterwards, we'll get a CAT scan to make sure it looks good, it's in perfect position, and then frequently we'll get a series of x-rays called a shunt series, so we can look at the entirety of the tubing all the way from the brain under the skin to the abdominal compartment and know exactly where that tube is. So we said that this is basically plumbing. It seems very straightforward. Typically, everything goes extremely smoothly. A patient spends a day or two in the hospital and goes home. But what can go wrong? I said that when you look in those fluid spaces, this is what you see. This is basically looking right at that area. And we have that choroid plexus. We have a series of veins. And if that tube hits one of those veins, what you get is this. And this is fresh blood layering in that cerebrospinal fluid. And the problem is that now that shunt's not going to work, because all those little holes are going to be clogged up. And we're going to have to start over and let the patient recover from this. So these are the immediate problems that can go wrong in the brain, but immediate problems can also go wrong on the distal end, down in the peritoneum. So when we look into that peritoneal cavity with a catheter, there's a lot of stuff that lives in that area. You've got the liver, you've got the intestines, the stomach. There's typically, this is what it looks like from the inside. There is a potential space between those organs and the peritoneal lining that we can sit the tube in. But if we're opening here, if there's scar tissue or we get in the wrong layer, we could potentially injure the bowel and spill bowel contents and impair the sterility of the operation. We could get into some of this fat and clog up the tube. So we want to be very careful at all stages of this. So what else can go wrong? Dr. Golomb talked a little bit about shunt infections. So these silicone tubes, they're foreign bodies. And bacteria love to live on foreign bodies. So they form a layer around here, and it's very tough for antibiotics to get in. Fortunately, shunt infections in NPH patients are extremely rare, much less common than when we do these procedures in kids. But if the shunt gets infected, we typically have to remove all of this tubing, treat with antibiotics, and then replace everything at a later time. Other problem that can happen is that we said that those little tubes can get clogged up. These little holes on the catheter can get clogged up, and now the fluid isn't going to flow through it. Here again is what it looks like in the ventricles, and very easy for that to get clogged up in this choroid plexus, which is very thin. Jen, are you able to show that video? So this is a video of using a camera where we basically we're going to drive the camera called an endoscope through the brain and get that in that fluid. So here we are coming through the brain. A little slow here. We're coming down, and now we're into that cerebrospinal fluid. And that sort of frond-like material is the choroid plexus. It's very easy to clog up the tubes. You saw the veins. These are the memory fibers wrapping around that came from the hippocampus that Dr. Golomb mentioned. Here we've gone deeper into the third ventricle, just getting a good look at all of those things. So this is where the tube is going to live. All right, we can go to the next slide. So other problems that can happen, again, very rare, but just so you understand all the things that can potentially happen, are that this tube running under the skin can break. It's pretty flexible, but over time the tube can become stiffer and it can potentially break. And then you have a disconnection. You have to replace that component. Also, the tube it's connected to the valve in this area. Every once in a while, the tube can fracture and then migrate along the path of fluid deeper in the brain. This is very rare. This was my case. I've had a similar one where we checked the scan and the tube had disconnected and was free flowing. This is taking a camera and going in and retrieving that catheter. You can see where it's before right here. So very rare things, but things we're going to watch for. You can also have plumbing problems deeper in the abdominal cavity. This is the tube entering the peritoneal cavity, and it looks like it's trapped in a web of fluid, in a pocket of fluid. When you look in there with a camera, what you see is all this scar tissue that has blocked up the holes, and now your shunt's no longer flowing. You've got to fix it. So one of the other things that can happen, and this guy wouldn't, most of the time these aren't major problems, but these are things we need to manage, is that you can have too much of a good thing. If we put the shunt in and we too aggressively drain cerebrospinal fluid, what can happen is that we basically are pulling the brain away from the skull and almost dehydrating it. And what this causes in the patients is what are called low pressure headaches, where every time they move the head, it feels like it's sagging away. It can be really impactful and cause problems if we drain too much. Alternatively, if we drain too much and we pull that brain away, we can tear small blood vessels and get bleeding around the brain, called subdural hematomas. The reason we get that is that there are small blood vessels that stretch from the skull to the brain. And as we pull this brain away, these vessels are sort of flapping in the wind and can be easily torn. Frequently, patients are on blood thinners these days, and that can make it bleeding worse. Again, this is a fairly minor problem, one that we can manage, usually without an operation. But if it's a bigger bleed, we may have to go in and actually take that blood away. We work very hard to avoid this problem. And one of the ways that we do that is by carefully choosing what kind of shunt valve we're going to place. So I told you there are about 200 different shunts that we can choose from. So in the past, we really had only what are called these fixed pressure valves, and we still use these commonly, but just not as much in NPH. And these valves work very well, but they're set at a single pressure, and the only way you can change them is by opening the patient back up and changing out that valve. And they typically range from low pressure valves that will drain at a lower pressure to higher ones that will drain at a higher pressure. And the problem is that know that patients are more likely to have overdrainage if we set the valves lower because it's going to drain more. But there's always going to be a few patients that even at a higher initial setting are going to run into those overdrainage. So again, the problem with the fixed pressure valves is the only way to fix it is to change the whole system out. Ideally, what we don't want is we don't want to put a high pressure valve in. Here's the height of a dam, and we're not getting any CSF flowing because we've set the bar too high. We also don't want this situation where we've set it too low, and now CSF is pouring out too much, and the patient becomes symptomatic from low pressure. Ideally, what we're getting is this very tightly controlled flow of CSF in the patient. The other challenge is that each individual patient can vary in what's the appropriate setting. So most people tend to have the optimal setting in this mid-range, but some people need a higher pressure, some people need a lower pressure. So more commonly, we use these adjustable valves. This is what's called the Codman-Hakima valve. Again, we have no stake in any of these, but this one's nice because it has 17 different settings. We can finely manipulate how much fluid we're drawing. The challenge with this valve is it's a big suitcase you've got to lug around to reprogram it, which always looks funny when I'm on the subway going to my New Jersey office carrying this big suitcase. The other challenge is that the only way to really know exactly what setting you're at is to check an X-ray and confirm what it is. The other thing is that all of these valves are controlled by, we adjust them with magnets. When patients get an MRI, which is getting at some point, they can reset this to a different setting, and we have to check it in the office. There are some newer technologies that have just come on the market that have some different settings that are attractive. This is a valve that it's nice because it's MRI compatible, meaning it won't change with an MRI. It's got 7 different settings. It's even got what's called a virtual off, where you can set it to a very high pressure and turn it off. So what does it look like for the patient? So typically, the patient will come in, we're thinking about placing a shunt. We're usually going to use the programmable shunt. We're going to choose initially, just to be safe, we're going to choose a fairly high setting that's only going to drain some CSF, but not get us into overdrainage. Place the shunt, make sure it's in good position, and then we're going to bring them back and say, have the symptoms gotten better? Is the patient, are all the symptoms resolved, or are they still having some of the problem? So if they haven't gotten any better, or they're only mildly improved, we're going to drop that setting down. We're just going to do that in the office with a magnet, repeat the process, bring them back in a little bit, check it again. And what we're ideally trying to get to is a setting like this. Here we see the CSF spaces have decreased in size. This is what they look like to start. And right around the edges of the brain, we're starting to see a little bit of that hygroma, CSF saying that we've sort of maxed out how much. At this point, we want to know, is the patient better? Are we having overdrainage symptoms? If so, we're just going to knock it back up one setting. The big problem is, what if we've done all this, we've maxed out our drainage, the patient hasn't improved? That's when you get worried that you might have the wrong diagnosis. You've got to go back to what Dr. Golomb said and go back to the drawing board and check on everything. So maybe in the interest of time, all right. So this is just a quick video that shows what adjusting a shunt looks like. This is courtesy of Codman. Here's the shunt in place. Here we are placing an alignment tool so we can over the valve. We're going to check what the setting is. So we line everything up and it tells us we're at setting 5. We want to adjust that, so we take a strong magnet. We're going to turn it from 5 to 4 to drain more fluid. The lower the number, the more fluid. What that's doing internally is adjusting this valve and letting more fluid drain. Now we're going to confirm it and make sure we're at the setting we want it to be. You can also check things with an X-ray, line up the X-ray, and you know exactly that we're at level 4, just like we expected. So Dr. Golomb alluded to, you can have what's called siphoning. There's a natural tendency when you stand up for the valve to for the shunt to drain more, basically gravity pulling the fluid down. So oftentimes, if we've got overdrainage, we may have to put in what's called an anti-siphoning device. And what that does is make sure that more flow doesn't occur when you transition from lying to standing. A lot of different types of anti-siphoning. This is a shunt that doesn't have the anti-siphon device. Here's one that does. This is that little part here that controls how much. So we've talked a lot about all the bad things that can happen after a shunt placement. Was this shunt really worth the risk? And overall, things really, for properly chosen patients, about 84% of patients improve after the shunt, especially in their gait, where almost everyone walks better. Dementia, urinary incontinence, those are more variable. I think one of the most important things, though, is this, that we can improve the patient's rate of functional independence, get them less dependent on others from about 50% to 80% after the shunt is placed. So there really is a lot of value. There's always going to be a portion of patients, unfortunately, where these are patients that improve after the shunt. There are going to be some patients that, no matter how carefully we chose, don't get better. And in that case, we've got to figure out what's going wrong. And the options are either that we've got a problem with the shunt, or we had the wrong diagnosis. So the ways we work through that are we can check what's called, obviously, the clinical symptoms. Have they had any improvement? Did they get worse? Does the shunt, it's got a reservoir, we can pump it and see if it pulls fluid in. That usually means part of the shunt is open. We can also stick a needle into that and drain the fluid out. We can check for infection. We can inject substances into there to see if the substance is now flowing through the entirety of the shunt, or is it being blocked in some area. So a lot of ways that we can assess the shunts, figure out if everything is working. Ultimately, there are going to be some patients where things don't get better, but I think in the most of the time when we carefully choose these patients, work over time to optimize the shunt to get them better. This is a patient that I operated on Monday. This is 1 hour after shunt surgery. Photo. You can see the incision on the scalp. All of the tubing is under the skin, hard to see. That going down the abdomen. He went home the next day. So thank you again to the Hydrocephalus Association. I know we ran a little bit long, but hopefully we'll have some time for questions.
Thank you so much. We are at the 8 o'clock mark. But Dr. Golomb and Dr. Farrell, if you're okay to stay for a couple minutes, we can field questions for people who are able to stay. I don't know what your time constraints are. So Dr. Farrell is able to stay. Just so that we can wrap up the formal part of the webinar before we move to questions and answers, I just want to thank our sponsors again. Thank you to Integra and Codman for sponsoring tonight's webinar. It was really informative, and we couldn't do it without you. And I just want to point out our resources that we have available in the portal of the webinar. And I also want to point out Codman's Life and pH website, which is a wonderful resource for individuals looking for information. So I'm going to go ahead and take a couple questions, and I'll mute when you're answering, Dr. Farrell and Dr. Golomb. But I want to take this question from Catherine. Sorry I missed this part, but why do some people have a quick lumbar puncture and some have a 3 to 4 day drain lumbar puncture? What are you testing for in a quick puncture, and should one expect an improvement after a quick puncture?
Okay. Can you hear me? Because I was offline for a little while. Can you just verify that I'm coming through here? Hello?
You're good, Dr. Golomb. We can hear you perfectly.
Okay, great. So the question involves whether what the difference is between doing a lumbar puncture and an extended lumbar drain. Usually a lumbar puncture, although it's very simple to do, it may not result in as much improvement as is often seen following a continuous lumbar drainage. And the improvement often is very brief, sometimes just for a few hours, rarely for more than a day or so. And so if there is improvement with a lumbar puncture, and it's pretty clear, then we can be confident that a shunt is going to help. If there is no improvement, then we'll usually recommend a lumbar drain. Lumbar drain is sometimes not as well tolerated. It involves being in the hospital for a couple of days or more. I don't know if that answers the question, but the nice thing about the lumbar drain is that the effect tends to last for a long time, sometimes for several days after the catheter is removed from the lumbar spine. So it gives patients and families more of a chance to observe things and get a sense or a preview, so to speak, of what might happen if they had a shunt placed.
Great, thank you. Curtis wanted to know if scar tissue from a radical prostatectomy is of concern prior to placing a shunt in the abdomen.
I can take that. Typically, no. If everything's been done outside of, not an expert in prostatectomy, but if everything's been done outside of the peritoneal cavity, where the prostate typically won't have anything, the more surgeries you've had in the abdominal compartment, gallbladder, ruptured bowel, those things, especially a ruptured gallbladder, can cause a tremendous amount of scarring. That abdominal compartment may be inhospitable to the shunt. So then we'll pick a different setting, either the lung or the heart. Or if somebody's had a prior shunt infection in there, that's usually when we pick other than the peritoneum.
Thanks, Dr. Farrell. Francois was wondering, when a post-spinal tap clearly shows NPH, and there is also a major cervical spinal stenosis, is it possible to determine which one influences symptoms the most and which one to treat first?
I think I can take that. It's cervical stenosis sometimes can give rise to hydrocephalus. It's pretty common to see the two conditions coexisting. If there is improvement following a spinal tap, we generally recommend that a shunt operation be placed before trying to operate on the cervical spine, particularly if there are no findings or symptoms that are referable to spinal cord injury. The converse, that is, treating the spinal stenosis in the hope of secondarily treating the hydrocephalus, although it does work sometimes. By and large, it does not, and patients do require a shunt operation.
I would also add that there's different degrees of cervical stenosis. So everyone, as we age, we get arthritis in our cervical spine, and that can be either minor and asymptomatic, or it can be severely symptomatic and pressing on the spinal cord and causing problems. So there's usually ways we can sort through that with the imaging and the clinical exam. So if the patient's having weakness in their arms and legs and their reflexes are extremely hyperreactive, they've got severe stenosis, their problem is probably the spine. If they've got minor stenosis, they don't have any of those red flags, and everything got better on the spinal tap, it's probably more the NPH. So you're going to sort of adjust to all of those variables.
Great, thanks. Dr. Golomb, in your presentation, you spoke about comorbidities with other forms of dementia, and a couple of people have asked this question. Are you more likely to get Alzheimer's with NPH or more likely to get a dementia with NPH, or are they independent? Does it open the door?
Yeah, well, the current thinking is that there are independent processes, but that sometimes we think of hydrocephalus as acting as a catalyst, that is to make patients who have an underlying neurodegenerative condition like Alzheimer's or Parkinsonism get worse at a rate that is much faster than they would have otherwise. So although we often can help people with shunt operations who have comorbidities, over time, sometimes the effect of the neurodegenerative condition can get worse and swamp the impact of hydrocephalus. And that's the point that I was trying to make.
Okay, great, thanks. Can you have NPH or large ventricles and have it not affect you, not need to be treated?
Yeah, very, very frequently. In fact, it's my feeling that there may actually be more asymptomatic hydrocephalus out there than symptomatic hydrocephalus. You often see very, very enlarged ventricles, dramatically enlarged ventricles, and people are perfectly fine. Often these are patients who've had hydrocephalus all of their lives. It's a congenital arrested hydrocephalus. That sometimes, for reasons that are not very clearly understood, does become symptomatic later in life, and patients can benefit from shunt operations or sometimes endoscopic third ventriculostomies. So just seeing enlarged ventricles in no way guarantees that hydrocephalus is the explanation for the problem. Symptoms. So that's a very good question.
Chris, Dr. Farrell, we're having a hard time hearing you. If you can come a little bit.
I think that's a very important point that Dr. Golomb made. We call large ventricles ventriculomegaly, and it doesn't mean that there's necessarily hydrocephalus, which is too much cerebrospinal fluid. Sometimes there can be some brain atrophy, which we all develop over time, and the fluid space is just enlarged to fill that spot. So we've got to put everything together before coming up with a diagnosis of NPH. It is not just because you had a CAT scan or an MRI and it showed big fluid, you don't necessarily have a problem.
This is kind of along those lines too, talking about diagnosis and determining treatment. Would you put a shunt in a patient who does not show improvement in a lumbar drain situation? This person who's asking this question says that he has heard that some patients still benefit from a shunt even if they show no improvement in the lumbar drain test.
Yeah, that's quite true. When we see improvement after a spinal tap or a lumbar drain, and it's pretty clear improvement, then that almost guarantees that a shunt is going to help you. The converse, unfortunately, is not true. Our approach is when we don't see improvement following a CSF drainage procedure, we look very carefully for these other comorbidities. And in patients for whom we really can't identify anything else that's likely to be contributing, even if there is no improvement, we recommend a shunt operation.
And for a shunt operation, is there an age where you would consider it too risky to place the shunt? Is there a ceiling, so to speak?
I think maybe Dr. Farrell ought to take that one.
I mean, I don't think age is. There's no magic number. We talk about risk factors for surgery. This is typically a general anesthesia procedure, and most of the risk comes from the general anesthesia. And age doesn't matter if the patient doesn't have heart or lung or other risk factors that make their risk of surgery so high. It doesn't matter what I tend to do brain tumors and hydrocephalus. We just wrote up our series of taking brain tumors out in patients in their 80s very well, so age doesn't really matter.
So this is an interesting, tough question. How often would you say patients are incorrectly diagnosed or that the NPH is missed? Is it now more widely detected by a family physician, or is it still more common to be misdiagnosed by a family physician and maybe not get referred on to neurology or neuro?
Yeah, well, Amanda, that is a tough question to answer because it depends very much on the practitioner. There's some internists, primary care physicians who are very good at recognizing patients who may have hydrocephalus. There are some who overestimate the probability that hydrocephalus is there, and some that underestimate it. I'm really not sure just how to answer that question in a global way.
I do know often when people call the association, we do always recommend a second opinion by a specialist, that they can do that if they feel like they're not getting an answer that's in their gut sitting well.
Yeah, I think that's true. It's better to be over-inclusive. It's better to suspect the diagnosis and then have somebody who's familiar with working patients up with this condition than to miss it completely. So.
Great.
That's what we recommend.
It is definitely an imperfect science in terms of diagnosis. And I frequently will see patients where someone thought they had NPH, and maybe they responded to a lumbar puncture or lumbar drain, or it clinically looked like it. They put a shunt in, and they just don't push the shunt far enough to get the clinical benefit. Sometimes you really have to make a bunch of adjustments to get the patient optimized, and that takes time and effort. And I think that's someone who's gone through the shunt procedure. You really want to make sure that the doctors treating you have made sure that they've done everything they can before saying the shunt didn't work.
Oh, go ahead, Dr. Golomb.
Well, maybe just one other way of addressing this point is with our practice. Of all of the patients who are referred to us for suspected hydrocephalus, patients with big ventricles and who have memory problems and gait difficulty, it's just a minority that go on to get shunt operations. I would guess it comes to about around 10%. So these are patients that we take very seriously. We have a very low threshold for suspecting the diagnosis. These are patients who get worked up with spinal taps and lumbar drains and all sorts of brain imaging. When it comes down to it, it's really just a minority who feel confident enough going to get better with the shunt operation, who actually go on and get it. It depends a lot on the minds of the institution. Some practitioners are more conservative and some less conservative when it comes to recommending surgery.
Dr. Golomb, are there long-term brain tissue changes with patients shunted with NPH who don't have other comorbidities?
Yeah, that's another great question. It's something that we don't have a great sense of. Many of us feel that patients with hydrocephalus who have responded to shunts and who have working shunts are not completely protected from the hydrocephalus and do get worse over time even when there's nothing else going on. We don't know why. We don't know whether there is a process that is active that's not being effectively treated, or whether it simply represents the effects of age interacting with some residual injury that hydrocephalus has caused, having been present for many, many years, even before a shunt was placed. It's a great question and an area that needs further research.
This is a question that we get a lot of follow-up calls on after individuals have been treated and they aren't seeing improvement, so they're concerned. How soon after surgery should improvement be evident? Can it be days, weeks, months?
Well, maybe Dr. Farrell wants to chime in here, but our sense is that most patients get better almost immediately. We see the improvement within the first few days. And it's, occasionally the improvement takes a little longer to manifest, but when we don't see any improvement after a week or so, we're beginning to suspect that we've
Yeah, I think it depends on what the treating physicians are doing, and every institution is and every physician is a little bit different. I tend to be pretty liberal with who I'll place a shunt in, but very conservative with how I manage it, because I want to make sure we do it in a safe and steady fashion. So frequently what I'll do is I'll put the shunt in. When you're doing that, technically there's always some drainage of spinal fluid just placing the shunt. So oftentimes patients will get immediately better, and then they'll get a little bit worse because I've set the valve high to avoid overdrainage. And I let them know they're probably not going to get better initially, but we're going to do this safely, slowly. And then I bring them back a couple weeks later. I make sure the CAT scan looks okay, and they're doing all right before I start getting them down to a setting where I'd expect them to improve. And every patient is different. Everybody needs to be sort of fine-tuned and find their own setting. So it depends a lot on what shunt's placed, what the initial setting is, and all those variables. But I'm trying to get them better, but do it safely.
Chris, I'd certainly agree with that. It depends a lot on what the pressure setting of the valve is. When we use non-programmable valves, then we usually see the improvement right away. And with programmable valves, we wait until adjustments have been made before passing final judgment on whether things are working or not.
In this patient population, what percentage of people have problems with their shunts after initial treatment?
So I think that it depends exactly. So all shunt patients, it's pretty common to have some problem over time. We see infections, malfunctions very commonly in kids, and it's not uncommon to have to change the shunt out many times. Fortunately, the NPH patients are less likely to have problems. But when you really look at the data, you find that somewhere between 10 and 20% of patients have some issue with the shunt, either too much drainage, infection. Those numbers are going down with the programmable shunts, but they're not going to zero. And problems still do happen.
So I want to be respectful of everybody's time. We can ask 2 or 3 more questions. The other option is that we can also take the questions that we didn't have a chance to get to, and we can email the answers to those questions. Just to answer one person's question, this is being recorded tonight. We will send a link for the webinar back out to everybody who participated this evening. Thank you all for coming, so that you can rewatch the webinar. I'm not sure, Dr. Farrell and Dr. Golomb, if you want to take 2 or 3 more questions, or again, I want to be respectful of your time and everybody's time on the...
No, it's fine with me. I'm here. I can stay for a few more minutes.
Yeah, same here.
Okay, we have a couple questions just about variability in symptoms based on days. So an example of this is coming from one of our participants, where she had a shunt placed in March of, I think, 2016. And some days she feels significant improvement, and other days she feels regressions. Why the difference? Why the variability?
Well, this may be something that Dr. Farrell wants to address also. We know that the rate of flow through these shunts is often positional. And so whether somebody is spending a lot of time on their back in bed or up and about may make a bit of a difference. But it's not uncommon for patients to experience fluctuations like this. Sometimes it does reflect the presence of comorbid pathology. Patients with DLB, dementia with Lewy bodies, are notorious for presenting with rather significant fluctuations in attention and awareness throughout the day and from day to day.
I think that's a very tough question and one we don't fully understand. I think that this is a very complex disorder we don't fully understand, and we're treating it with fairly simplistic plumbing options. So we're doing pretty well, but we're not doing great, and I don't think we understand all of the things that go into this. Some of it may just be that we're close to the right setting, but it's not optimal. And some of it could just be other stuff that's going on that's beyond the NPH that we don't fully understand or haven't diagnosed.
Okay, great. I actually think we do need to close up the webinar at this time. What I'd love to do, Dr. Farrell and Dr. Golomb, is Jennifer and I will take a list of the questions we weren't able to answer this evening, and we will be able to get those answers to people. We'll contact you and we'll get those answers to people, if that's okay with the two of you. Okay, great. I really want to thank everybody for coming this evening. I particularly want to thank our two speakers, Dr. Chris Farrell and Dr. James Golomb, for taking so much time to answer these questions, to do these wonderful presentations. There was so much information. I want to thank our sponsors one more time, Integra and Codman, for making this possible. There is a list of resources that you can find right here in this portal, but we'll also email all of those resources out to everyone who's participated this evening. Again, the lifenph.com resource is wonderful from Codman, and the Hydrocephalus Association has a number of resources available to all of you on our website. And of course, we're at the association answering questions, taking phone calls every day. If you need us, if you need answers to any questions, please don't hesitate to reach out to us. This is why we're here for our community. So I just want to thank everybody again for coming, and I hope everyone has a wonderful evening. If you're in a cold area of the country, stay warm.